Welcome to everybody. Thank you for joining us today at this event from PDPAL Project Consortium. PDPAL project is about palliative care for Parkinson's disease and is funded by the Horizon 2020 program of the European Union. We are pleased to have today with us Angelo Antonini, a prominent figure in the field of Parkinson's disease, which will be also the focus of today's webinar. I will now give a brief introduction about our project. The PDPAL project is a project about palliative care. It's still an ongoing project. It will end this year. And we decided to start this project focusing on Parkinson, as it's one of the scenarios in which palliative care needs to be improved and spread. In fact, Parkinson's disease patients have considerable and mounting unmet physical, psychosocial, and spiritual needs. We have also some barriers and challenges to face. One of them is a linguistical one. In fact, palliative care is often understood as a synonymous of end of life and terminal care. Our overall mission is to validate a new model of care that is to be integrated in the current management of Parkinson's disease, especially in the late stage, by not only involving healthcare professionals, patients, and caregivers, but also our mission now is to pursue an educational path involving more and more students from healthcare professions to be familiar with this concept that should be a pillar in the management of Parkinson's disease. Our consortium consists of 10 partners from 7 different European countries, and a lot of partners and projects are also joining us, like the European Parkinson's Disease Association and the iCare PD, which is also an European project trying to improve care pathways for Parkinson's disease. The objectives we are trying to reach are developing guidelines and recommendations to understand better when palliative care needs to be delivered. We are also doing a clinical study based on a community care-based intervention with a nurse intervention that is aimed to taking control of everyday symptoms, but is also allowing patients and caregivers to think about disease trajectories and disease course, and also express their wills. We are also, as I mentioned before, this educational path. So if you go to our site, pdpal.eu/MOOC, you will find our massive online open course, and we are inviting you to join us on this. I want to thank again all our partners that are supporting us, and of course the European project. And I want to thank again our speaker today. So I'll leave the stage to him, and I hope you all enjoyed the webinar.
So thank you, everyone. Thank you, Dr. Garon and Dr. Pal, for letting me speak about Parkinson. And I'll share my screen and I'll briefly try to summarize what are the key aspects of Parkinson's disease. And it is a difficult task, to do it in a relatively short time. So I think Parkinson has so much historical background and there has been so much happening over the last 2 centuries since James Parkinson reported the disease in a booklet. Then it is difficult really to provide a comprehensive and effective overview of what the disease is about. First, I think that the current scenario in Parkinson is such that we are still relying on manifestations or motor symptoms, which are essentially the same that James Parkinson reported in his booklet and Jean-Martin Charcot highlighted in his 5th lesson 50 years later. However, over the various decades, additional knowledge has come up, and I think the main milestones in Parkinson's disease are represented by the discovery of the importance of dopamine, by the fact that inclusions in the brain are present in people with Parkinson, and that the substantia nigra is the site where the pathology brings motor disability to light. James Parkinson described only 6 cases in his booklet, and Charcot reported only a few patients in his clinical experience that is collected in his lessons. However, it took almost a century before Arvid Carlsson, a physician, neurologist in Sweden at Karolinska, published an article where he proved that using a medication that depletes the brain from catecholamines, he was not aware specifically that he was acting on dopamine, it could produce rabbits with symptoms which resemble a lot Parkinson's disease. And the motor manifestations, I think, were captured in this slide, where he showed the rabbits apathetic, very slow, lying down on the ground, and immediately thereafter, after the injection of levodopa, which is the large neutral amino acid that we still use and we still consider the gold standard in Parkinson, he was able to refill the catecholamine system, and specifically the dopamine system, with dopamine, making the rabbits able to walk again and move around in the cage. Even if this publication, which represented, I think, in medicine a major breakthrough to the point that Carlsson was awarded the Nobel Prize in the year 2000, it took about 8-10 years before this man, George Koutsias, proved that the levodopa therapy was effective in Parkinson's disease. At that time, there were no formal clinical trials. I mean, in our European project, even if we're just dealing with palliative care, we had to struggle to prove, to submit all documentations and get it approved by the ethics committee. At that time, it was more based on empirical evidence and on the fact that people just were, doctors were testing the medications in their own clinics, something which today would be considered unacceptable given to the risks that are associated with this practice. However, Koutsias was a Greek doctor living, working in Brookhaven at the end of Long Island, and he had time to give levodopa to the patients, because at that time, sounds incredible today, but Parkinson patients were admitted to mental institutions as much as people with schizophrenia, people with Huntington's disease. They were all together, and there were hundreds of them, because Parkinson was considered to be a mental disease, or in addition to the motor disease, due to the fact that people were off in the advanced stage and were unable to speak, unable to communicate properly. And there was a perception that the understanding in the late phase was always affected due to the bradyphrenia and slowness in brain processing. So we gave levodopa, and he saw that some of his patients started to walk again. This has been nicely captured by Robin Williams in the movie Awakenings several decades later. Koutsias unfortunately died for lung cancer because he was a smoker. So even if he would have deserved the Nobel Prize as much as Carlsson, he could not get it, because in the year 2000 he was dead. So the Nobel Prize goes only to alive scientists. And another discovery, which I think is relevant for our treatment today, is the presence of these inclusions in the neurons that are dying from Parkinson, aggregates of proteins, which we did not understand very much and very well for more than 80 years. Friedrich Levy reported them because they were quite large and visible with microscopy. But he didn't know exactly what the content of this Levy body was. And it has been only at the end of the 90s, at the beginning of the new century, around the year 2000, that it became obvious that these Levy bodies included specific fragments of a protein that has become a key in current understanding of the pathology, which is the alpha-synuclein. Now, these alpha-synuclein aggregates were not aggregates of the entire protein, but of a fragment of this protein. And how the people became aware of this? It was thanks to the discovery of a genetic mutation that was associated in this first publication that was released in 1997 by Dr. Polymeropoulos and Larry Golb in the US, where a family was identified, a Greek-Italian family with some branch living in Italy, one living in Greece, and another one living in Canada. And this family had the same roots, and Parkinson was very predominant in this family. There were many people affected. That allowed the researchers to identify the mutation, a mutation that was associated with the clinical manifestations, and the mutation affected this protein synuclein, and it became obvious shortly thereafter that synuclein fragments were aggregating in the Levy bodies. So Friedrich Levy observed the Levy bodies, and thanks to Larry and Gold JB, and then to Polymeropoulos, I think it was obvious that Levy bodies were just aggregates of fragments of a protein that was badly degraded in the brain of people with Parkinson. And since then, in the last really 20 years, research in Parkinson has really picked up at an incredible speed. You know, things that we were not that much aware about the significance. You know, for instance, we know that Parkinson begins typically in one hemibody, and this is one of the mysteries, you know, because you say, well, if there is something wrong with a specific protein, why only half of the brain should show more profound degeneration compared to the other? You know, when Carlson gave a dopamine depleter, reserpine, to the rabbits, they manifested bilateral symptoms, but somehow, for something which we still haven't understood properly, you know, the disease begins, affects more one nigral part compared with the other. And this is relevant because even people may die 20, 25, 30 years later, and you look at the brain of those people, still you see an asymmetry. So it seems that there is a vulnerability factor, even within a specific group of neurons. And another important aspect of the disease, which we are now increasingly investigating, is the fact that Parkinson is no longer viewed as a neurological condition. We can find the hallmarks, the fingerprints of the disease, these aggregates of synuclein, not only in the brain. If you do a skin biopsy, or you do a gastric biopsy, or a jejunal biopsy, you will find the same pathology. So Parkinson is indeed becoming a really disease of the entire body. It is cannot be fully considered a disorder only of the brain. This is relevant because, you know, our patients, our people with Parkinson start manifesting a number of symptoms which are frequently not related to the degeneration in the substantia nigra. So even if Carlson and later, you know, Levy and Andy Singleton, Golby, they were all focused on synuclein in the brain, possibly James Parkinson was wrong, and that this is a disease of the body rather than only of the mind. So this is something which we face every day. We see a Parkinson person and a caregiver of a Parkinson person in our clinic. I think another relevant aspect is that we have learned in the last few years is that having one pathology doesn't exclude concomitant additional pathologies. And indeed, in about 20% of people with Parkinson after the age of 70, you not only find this Lewy body pathology, so aggregates of synuclein, but you also find aggregates of amyloid. And this is particularly relevant because we know that cognitive dysfunction is one of the symptoms that affect the late stages of Parkinson. Well, our research, as the research of other groups, have demonstrated that 50% of people with moderate to severe cognitive deficit with Parkinson have at least a double pathology. So they have Lewy body and amyloid aggregates. So if we want to tackle this disease, it may not be sufficient to target synuclein, but maybe you need to tackle also additional proteins in the brain. Now, if in 1997 the discovery of this synuclein mutation represented really a breakthrough in this chromosome 4, now you see we have more than 23 or more mutations that have been associated with Parkinson. So it's getting more and more complicated. And also our view of Parkinson has changed, as I said. You know, this is just an example I like to show in my talks of a family which we learned about only starting from a woman. This lady came to see us when she was at the very beginning of the disease. She had just presented some tremor in the left hand, but she had other symptoms that we know now are related to the Parkinson, like mood changes, reduced smell, and they had started years before. But when she came to see us, we, as many of us, focused on the presence of some tremor you see here in the left hand, some modest slowing, and we made a diagnosis based on clinical manifestations and on confirmation of additional imaging scans like dopamine transporter. Now, we then learned that there were other people in the family, at least a cousin. So we did a genetic screening, and we found that in this family there was a mutation that was manifesting clinically in some. In others, it was there, but it was not giving any clinical evidence. And this is her brother. Her brother in 2013, he has the mutation, the genetic mutation, which is called the LARC2 mutation. So it is a mutation of kinase, which somehow facilitates aggregation of synuclein fragments. This man was used to run, to be very, very active. He was carrying a mutation, and we asked him to participate to a research protocol where we also assessed his dopamine status. And to our surprise, even if he was normal, his dopamine was severely reduced. So if we had to stick to the James Parkinson description, he was normal. If we had to apply the criteria based on genetic, he was at risk. And if we used the criteria based on imaging, reduced dopamine transporter, reducing dopamine system cells in the brain, he was ill because his scan was not different from a sister. But again, we have kept following this man, and it is very intriguing that even 5 years later, he is still okay. And then I don't have time to show you the video of this year. He has retired, has put up some weight, but he's still okay. So he's living possibly very nicely with depleted dopamine system and with a genetic mutation. And we still don't know why in this family, which we reported, the mother, who has some moderate loss of dopamine cells as well, she the entire life. She's 85 now, and she has never developed symptoms. So even if this mutation is a dominant transmission, is being the most common genetic cause of any neurological disease, because it's the most prevalent form of Parkinson, genetic Parkinson, for instance, in the Mediterranean area, in Spain, but even in Norway, so in those countries where there were contact with the southern Mediterranean regions, still only 30% develop the disease, and others, they may live entire life with a depleted dopamine system. This is even becoming more complex as we have expanded our understanding of the disease to patients we would have never thought that they had Parkinson. Like this woman, she was born and she became quickly orphan and was adopted. She started with slowness and difficulties in walking at the age of 5, and she had some dystonic features. So she was tested on levodopa when she was 20, and we saw her when she was 50. And if you look at her, you would not see much of what we understand today based on James Parkinson description to be Parkinson's disease, because she has mainly axial symptoms, difficulties in speaking, severe postural instability, and so on. And she had a very, very slow progression. Actually, if you read the notes of in the early 1989, when she was admitted to the hospital here in Padua, she looked quite similar. Now she doesn't. She has a Parkinson's disease technically because she tested positive for a mutation of the Parkin gene, which is the second mutation and the most common recessive mutation in Parkinson's disease, with several thousand of patients all over the world. So the time of diagnosis, as we have been understanding Parkinson, possibly is based only on the description of the booklet on the essay of shaking palsy, but is wrong in terms of the biological diagnosis, which actually today, to our knowledge, could be possibly made already in a preclinical or even a prodromal phase. The problem is that many of the preclinical prodromal cases may not turn Parkinson, as Parkinson patients do not develop necessarily the disease years later. But let's come to our management of the disease. I think, what we know today is that we are allowed to start medications, at least symptomatic medications, when we see the symptoms, the motor symptoms. And typically, when we see the motor symptoms, we start with dopaminergic therapy, which is something which has the objective to refill the dopamine system, similar to what Arvid Carlson did. Now, how do you approach the early stages of Parkinson? We have our own data set, and many of others have their own data set. The largest database, open database of Parkinson patients at the early onset, newly diagnosed, is available through the Michael J. Fox Foundation. It's called the PPMI, the Parkinson Progression Markers Initiative. Based on PPMI, I can tell you that as of today, pretty much, a significant proportion of patients start with levodopa, which is the amino acid that is used to rebuild dopamine in the brain. Others start with a synthetic dopamine, which is a dopamine agonist, and a smaller proportion utilizes enzyme inhibitors at the beginning. Only a very, very small minority is left untreated, and this is something which, at time of diagnosis, I feel it is a bit inappropriate, in my opinion. So as far as the characteristics of our medications is concerned, the levodopa, as I said, is a large neutral amino acid, and the large, as such, it is transformed normally in the periphery to dopamine, which we now block with an enzyme inhibitor. This was not the case at time of Cotsias and Carlson. So the medications we use in Parkinson essentially include levodopa and an enzyme inhibitor. And this enzyme inhibitor, which could be carbidopa or benzerazide, depending on the formulation, is administered to prevent the transformation of levodopa in the liver into dopamine. This is important because levodopa, as an amino acid, not only it has to be transported into the bloodstream from the intestine, but also from the blood, it has to cross the blood-brain barrier and get into the brain. Now, how can we make this levodopa availability bigger? So how can we expand levodopa efficacy? As I said, the standard way is to give levodopa with a dopa decarboxylase inhibitor, blocking the build-up of dopamine in the periphery, which is the main pathway, metabolic pathway of levodopa. Another approach is to combine the dopa decarboxylase inhibitor with another inhibitor, an inhibitor of another enzyme which is important in levodopa metabolism in the periphery, which is are the catecholomethyltransferase. This enzyme, the catecholomethyltransferase, are an enzyme which are is located in the liver, and it is very important in all detoxification processes. So adding a methyl group is a standard way our body has to eliminate substances in the body. Now, since this pathway is blocked, a significant proportion of levodopa, at least that our body feels to be in excess, is eliminated by this other enzyme, which we can block with a specific inhibitor. Then we have maximized the amount of levodopa getting into the brain across what we call the blood-brain barrier. So here we are in the brain of a patient with Parkinson, and particularly in the dopamine neurons, where levodopa, it is transformed to dopamine. Unfortunately, this process is done by the neurons that are degenerating the disease, and this is the reason why levodopa benefit shortens over time. So we are in the brain, particularly in the dopamine cells that are surviving, and the transformation of dopamine is done there, and this is ensuring the release of dopamine into the extrasynaptic space to make sure that people are mobile again, like it's been shown in the movie Awakenings. We could use other drugs to block an additional metabolic pathway, this time of dopamine, which is generally degraded by the monoamine oxidase, and blocking the B part of the monoamine oxidase, which is an oxidation process. So adding an oxygen atom to the dopamine allows its metabolism, but inhibiting this pathway is important if we want to extend dopamine half-life. And we have drugs to block the catecholomethyltransferase and to block this additional enzyme. As I said, at the beginning of the disease, the number of dopamine cells which can still make this process is reduced, but not too much. It is reduced by about 50%. As disease progresses and people reach a more advanced stage, this reduction may reach 80–90%. So if this was the image of the early Parkinson in Muhammad Ali and Michael J. Fox, after 5, 10, 15 years, they may reach this stage, and you see how much their not only physical but also motor aspect has changed. Here, quite dynamic. Here, very much staring gaze and showing hypomobility, and maybe also a lot of physical changes, relatively short time. So the challenge today in Parkinson is really how can we best manage this phase of the disease, and how can we best manage the fact that people start developing changes throughout the day in their clinical state, and particularly that during the off phase, which is a period when the effect of levodopa starts wearing off, so diminishing and disappearing, symptoms begin to return, and people need to take an additional medication in order to be again mobile and able to walk, move, and speak normally. These repeated intakes of medications throughout the day have a negative impact on functionality of people with Parkinson. And in addition, this reduced benefit that you might see from levodopa therapy after about 3 hours is not only associated with the reappearance of slowness, bradykinesia, but also with the appearance of symptoms which are not necessarily related, immediately related to the Parkinson. So if you use a questionnaire and you ask people, what are the symptoms that you manifest during the off phase, they would tell you maybe, yes, I have tremor, but I have anxiety, I have mood changes, I feel my mind not pretty clear, I feel pain, I have painful muscle cramps. So these conditions are occurring every 3-4 hours in people with Parkinson. And you keep shortening the interval, increasing the number of medications, adding these enzyme blockers in order to make people more functional throughout the day and experiencing less and less of these manifestations. This is not easy. You know, this is a lady which I show because during this what we call off phase or phase of poor efficacy of levodopa, she not only has rigidity and bradykinesia, but she feels also terribly depressed and in pain, and her pain makes her screaming, seeking for help. Her husband doesn't know how to deal with it.
Devi bere.
And he's telling her, you should drink some water, because that will make the effect of the medications faster. But you see, she's crying, she's imagining that everything is gonna end, that her life is finished, and she has pain from these muscle contractions. After taking levodopa, she's very different, and this is how I saw her in the clinic most of the times, you know, because she came, this is in my office in the clinic, and she was walking, she has some modest cognitive deficits, some balance problems, and this is actually quite remarkable difference between the two conditions. This is you know, difficult to capture, because when people come to the office, they are frequently under the effect of drugs. Now, as I said, and I don't want to spend too much time talking about specific drugs, but again, how do you extend the levodopa effect? We said levodopa is a large neutral amino acid, so to extend, and this pathway is already blocked, so you could use blockers of the catecholamine transferase like entacapone or opicapone to maximize the amount of levodopa that gets into the brain, and this levodopa will be then transformed into dopamine by the surviving neurons, and we can best extend the effect of levodopa, dopamine, in the brain, specifically dopamine, by blocking this monoamine oxidase B, which are present in the glial cells and are responsible of the degradation of dopamine in the brain. And we have some like rasagiline, safinamide, which are the most, or selegiline, and they have various effects in some cases, like in the case of safinamide. They may act also on glutamatergic transmission. In terms of catecholomethyltransferase blocker, again, this is something which occurs in the periphery, and it has the objective to maximize the amount of levodopa getting into the brain by blocking both enzymes. This is the scenario. This one on the left is a scenario we saw with Cotsias, with Carlson, but is no longer available because we use dopa decarboxylase inhibition. But on the top of that, we may block the catecholomethyltransferase too. And this has been shown here with entacapone, but much stronger with opicapone, 50 milligram. We can reduce additionally the duration of these periods of poor mobility, which we call wearing off, by adding these additional medications. Now, in the last part, I would like to touch base with some additional symptoms. For instance, involuntary movement, dyskinesias. Dyskinesias are related to the intake of levodopa, and they could be quite troublesome. If you see here, these two men, they are both suffering from Parkinson, but when they take the levodopa, and when levodopa starts becoming effective, they develop these terrible involuntary movements that are as disabling as the off phase. Now, what to do with them? I mean, we don't have many drugs. We have amantadine, which we know can reduce the severity and the duration of these involuntary movements, but the opportunities are limited, and therefore I think the Canadian guidelines, but also most guidelines in the world, tend to emphasize that the importance of discussing with people with Parkinson the therapeutic options also at this phase. So to start planning ahead for the possibility to do surgical therapies like deep brain stimulation or infusion therapies, or in case, and we will discuss it later, taking into account the importance of palliation and palliative care, which in Parkinson, as a Canadian wrote here, should be considered throughout all phases of the disease, because this is not related to necessarily the period when the medication effect tends to end or becomes really minimally relevant, but it relates to the entire management of the disease and the planning that is associated with the choices, the therapeutic choices. For instance, for these device-aided therapies, we have proposed, I have suggested, that use simple messages to gain attention from the medical community, from the general neurologist, the physicians at home, and maybe the people who have reached, already 5 times or more intakes of levodopa a day. These people possibly should be considered for these treatments, or if they have 2 hours of time with severe disability, this is possibly relevant, or if they have dyskinesias, this is also relevant. And I think it is relevant because we have alternative therapies, more invasive, like subcutaneous apomorphic infusion, duodenal levodopa infusion, or deep brain stimulation, which I will not discuss today, but are relevant in the management of Parkinson. And the number of patients coming to these treatments is relatively small, but not because they are not there, but mainly because they are not referred to the institutions in charge of this. So I think, that we can conclude saying that the progression of Parkinson should be focused on functional disability and on loss and worsening of quality of life. I think we have a number of instruments now that can help us monitoring the disease between visits. For instance, device therapies or these therapies, advanced therapies, require constant monitoring. You could use mobile health technologies to do so. In PDPAL, for instance, we use PD Monitor to this end. But I think, to conclude, it is really mandatory that we try to set a proper environment and start discussing with people with Parkinson the therapeutic options from the beginning. Maybe the time of our diagnosis will even change in the future, and we will start considering Parkinson even those people who do not have motor disability. Nonetheless, the presence of a multidisciplinary team, of a good approach to these patients is essential. And with this, I say thank you for your attention, and this is our team in Padua, where we try to set up a multidisciplinary approach, utilizing money and funding from private donors, from research projects, and from the hospital service. Thank you very much.
Thank you very much for this very illuminating and clear presentation of the modern and current challenges and things that we know about Parkinson's disease at this point of time. And we hope that via the projects that have been launched, we gain more and more knowledge. And this is maybe also my first question to you, that what was your motivation of starting the PDPAL project that we have been doing together now? So what was the driver for that?
Thank you, Piretta. I think, that the main driver was realizing that with disease progression, we were not able to properly follow our patients because the mobility became worse. There were more logistic problems in getting to the hospital. And when we conceptualized PDPAL, remember, it was well before COVID, telemedicine and telemonitoring were not even that much used. We were at the very early stages of this. I think COVID, with all its negative and the deaths, which are always very sad, at least has left us some knowledge on how can we best follow people in their homes. The awareness that we cannot simply rely all our indications to the hospital visits, the 15-30 minutes that we have. This is totally insufficient because we lose track of what happens at home between the visits. And that old lady that I showed the video at home was sent me by the husband because when I saw her, I never saw her crying. So I said, well, I think I need to see what's happening at home. Why don't you take a short video? And now this is, I think, has become increasingly the case. I receive a lot of videos over WhatsApp, so from patients when they want to show me something which they think it's unusual. But it is the proof that we need to properly plan, and it is the proof that the disease progresses and the doctor is not progressing because we still use the same method as at the beginning of the disease. Hospital visit of 15-30 minutes and people come into the examination room like, maybe James Parkinson did. But that was 200 years ago.
Yes, and this leads to the next question, which is now more related to your presentation that you showed us how the knowledge about Parkinson's disease has developed a great deal in the past 20 years, or maybe 25 years, let's say, roughly. And then we know that we have GPs who are mostly responsible for diagnosing also Parkinson's disease. but we know that in Europe also the population who represent GPs is getting older and older all the time, so they don't have the newest knowledge. Is it I wouldn't say that it's a public health hazard or something like that, but it definitely delays the proper diagnosis. How can we educate people who already work in this field for a long time, and how can we bring this newest information to people who are established GPs and work in their communities?
Well, I think you raised a very important point, Piret, because there are two issues. One, GPs are getting older, but I think the most critical one is that there are no GPs and nurses, because we have not been that good in planning how we should care of our European population, because most of my patients are remaining without GPs, because nobody wants to be a GP in a remote area. The mountain region is totally off any specialist. So this model of care, I think, like we were used to, is facing big challenges. I think, this is a good instrument. I think having a shared platform, what we are working locally with the health authorities, is in creating a platform that can be accessed by all specialists dealing with a specific patient. And this is, I think, is going to be tested for Parkinson among the very first diseases of the body, because Parkinson is an excellent example from both the pathophysiology and the clinical manifestations that you need to make the neurologist talk with a nurse, talk with a cardiologist, talk with a gastroenterologist. And if a GP wants to understand the disease, they need to see that on their desk, not on your computerized system, there are all these evaluations, and that, I'm sure, is the best way to educate them together, maybe with teaching courses and training. Because really it is a complex condition, particularly as disease progresses. I think the importance of having a multidisciplinary approach, and particularly of bringing this multidisciplinary approach all together in one platform, that people can see that what the patient, that the person has done is relevant. It happens to me that when patients, our hospital here is quite big. We have more than 2,000 beds, and it is not infrequent that patients are admitted in other departments and I'm not called, and the people don't realize that Parkinson deserves, then I'm called because, something is wrong, your patient is no longer moving. And they simply forgot to give him levodopa, or the patient had a gastrointestinal problem, surgery or whatever, and they could not swallow. And they don't know how to deal with that. We need to have guidelines on management of people with Parkinson when they have delirium, when they have a fever. This stuff I think is important for the GP, that, very frequently I receive the message, your patient, there is nothing, I get called from the relatives saying, there is nothing we can do. I was told, my father has become demented within 2 days. I said, well, this is obviously not the case of Parkinson's. This is maybe there is a bladder infection, there is acute constipation and abdominal problem, or COVID was a good example. People were intubated and then they woke up, no medications in the intensive care unit, and then got very rigid, unable to talk, unable to swallow, and then with the cubitus and the conditions aggravated quickly, they can get back to relatively normal life. You can reestablish treatment. But this knowledge, I think, these projects are important, because we need to make our effort to reach the general medical community, and everyone is caring for these diseases.
Yeah, I think it's also patients' concern that because you now quite clearly demonstrated us how Parkinson's is the disease of an entire body. And I think that this can be basically said about any condition one has. And so either if it is cancer or some other life-threatening condition, it affects your entire body. And the patients are very concerned that if they have some issues besides which is not directly related to their diagnosis, then they have to go to very different specialists who are then responsible for that, but there is no collaboration between those specialists. And this is, of course, time consuming. And also, well, we know that if the needs are not met, then people lose their faith also in healthcare systems, and then they seek help from all kinds of places where, and yeah, but now when we come, you demonstrated also that Parkinson's can manifest in people who don't have any symptoms, which is interesting. And I think that we have screenings, because I mentioned for cancer, for example, in families at least who genetically, you can attend the screening, genetic screening even. Would it be a good idea and a sustainable idea also, like to put our effort more in this kind of screenings also, so that people would know that, okay, I have maybe the precondition, but then I can do something, for example, run a lot, and then my body creates its own dopamine. so that if they would know already before, so it's more the prevention part and not the treatment part yet. Would this kind of screenings make sense in our society?
Now, this is a difficult topic. We are slowly seeing new drugs specific for people who have mutations, genetic mutations. So the genetic screening is increasingly becoming relevant. However, this creates also issues in terms of counseling, because as I showed you, here you have two siblings, one lady who has Parkinson, the brother with 2 years younger with the same mutation, no symptoms, but dopamine loss. They both have children who are grown up, and they're going to have grandchildren soon, because they are 70 or so now after 10 years. What are you going to say? Well, I said, look, this disease that you have, it is called Parkinson, but it is related to a specific mutation. We don't understand yet why in some people it produces symptoms, in others it doesn't. But do we have the capability to do this in a large scale, considering the number of cases? How much counseling can we provide? Is our health system ready to do, like we do a genetic panel with 90 genes, 90. We get a lot of variants which need to be explained, as the geneticists say, oh, this is a variant of unknown significance. It is unknown to them, but if I had a variant, I would be worried for my family. Say, well, what's going to happen to me? I have a genetic variant. It is unknown simply because today we don't have enough knowledge. But maybe in 5 years, it means that in my family, Parkinson may occur more frequently. So I think, it is a double-edged story, because I think it is important for scientific reasons, but we are not ready yet to do this. So we should think more carefully in specific forums how to manage it, because this has an effect on end of life too.
Mm-hmm. Yes, because I'm just thinking also that, for example, for breast cancer, there are this kind of screenings, and it of course results in certain amount of psychological distress as well, that if you know that you have the tendency or the possibility that you might get it, but then you have the invitation to make life changes, because we know that of course prevention is always much cheaper than the treatments. So it would be of course interesting to see how this develops. But and that's why I come to my maybe research related question, that we have of course this genetic databases that we can obtain information, but there are also brain banks that produce interesting information also for Parkinson's and other neurodegenerative conditions. So what kind of information can we gain from the brain banks actually? And this, so in terms of the people who have this disease could make also informed decision to support science also after their death.
Well, yes, I think the brain donation program, we have even something more complicated, which is called the body donation program. So you can donate the entire body. Mm-hmm. And it is stored in our Institute of Anatomy, and then we can examine, because I think, as I said, it is a disease of the entire body. So we want to know what happens in the brain, yes, but we want to know what happened in the brain and in the gut, mm-hmm. and in the heart, which is also affected, by the way, in these people. I think this kind of activity is quite critical. It's a difficult topic, I think, because many people think, donating your body to science is not going to affect them, because, I'll be dead by then. So it is not going to be beneficial to me. But it's going to be beneficial to humanity, I think, because what we learned, and I showed you about Friedrich Levy discovering the Levy bodies, or Teryakov discovering that Niagara was involved. It was possible because people donated their body and their brain, because otherwise we would have never known that there were Levy bodies. So if you don't examine the brain, if you don't examine autopsies, this is, on the other hand, common practice these days. Even in medical legal field, having an autopsy, it is required to understand the legal issues related to the event, but scientifically it's the same. So I think we should encourage these programs. We should have a database where we could inform patients and families about the importance of participating to these programs, which are an act of donation to the humanity, I think, to the knowledge that we have, which has helped us improving in the last 20 years dramatically our knowledge, specifically in Parkinson's disease.
Yeah, so it's maybe again one reason also why we as clinicians or also teachers should encourage people to think about death and dying also. So even if we live most of our times, but also that what happens and what can we do also when our lives have ended. So probably one topic that should be also part of the advanced care planning, for example, and
I think,
yeah,
information on what to do with you when you're not going to be there anymore, how much of you, of our body, of our presence could be of help to science and to other people. This is similar to organ donation, which is, there are different legislations now in Europe. I think it's getting more uniform thanks to the EU effort. But still, I think informing about the importance and what it is used for, I think it should be discussed in the patient community, with caregivers early.
Yeah. Yes. Yeah. And now maybe my final question then would be that during this, you work broadly across Europe, and you mentioned that the laws are very different across the Europe, despite the EU and European Council and all these organizations who want to unify us. So what has been like for you the most striking thing when you have been in some country and you have been thinking, oh, that we should have it in Italy, or something that you have learned from those collaborations?
No, I think, we what I think it would be important is to make it to make our efforts more synchronous. One of the problems of science is that is the Nobel Prize syndrome, I call it. So everyone would like to win the Nobel Prize, because the Nobel Prize is won by one or maybe two, and the others don't get it. You want to be the one. It's like winning the Olympics of science, is similar. And the competition is good, but the competition, I think, is making also, it has a distortion effect, in the sense that you think that what you do is more important than what the others do. And you tend to, our brain works that you suppress what is you value not important. So you discount what is not important, and you overvalue what you empathetically think it is important. Now, this is today a disaster, because there is this is like the multidisciplinary management of Parkinson. In research, it is impossible to do a discovery by yourself, because the science is so complex. I think what is needed, it is needed more efforts, more joint efforts, and more transparency on the work of everyone, reporting early. I understand that patents are important. There is an issue of funding, but these EU projects, I like them a lot, because at the end, what is left from an horizon is not lost. The horizon evaluation values also how much you can integrate previous horizon projects, and brings Europe together. This is not always the case at a national level, but it is becoming increasingly so. I think even what I saw that was common in the Anglo-Saxon environment maybe 10, 15 years ago, to work, I remember the MRC or the NIH system when I worked in the US. Now it is becoming a factor also here in Europe. And I think both at the EU level, but also at the national level, where if you present a project, you need to link it, to give it a European spin. How much is this the product of a joint collaboration? They give you points in the evaluation. Minimizing your personal contribution, emphasizing the group contribution. Then, of course, and then I finish, I think the academic world is made by people who have strong personalities and egos. So this is something which I think will change very little, because that there is this intra-academic competition, who's the best man. I think more women are needed. We just had women elected as a rector to balance this excessive, I think, man-driven world, which creates a lot of frictions at the end. It's not very constructive.
If I understand you, yeah, if I thank you for also mentioning women and their contribution to the science. I think it's very important, and not in all countries, but in many European countries, it is still a huge issue. And but I don't think that women will solve all the problems. It's the collaboration, as you told. And I think also that maybe we should all be handed a 9th ribbon in Nobel Prize, and so we could continue from there. So all our egos will be then soothed, and then we can work together on an equal basis. So yes, so thank you very much. Thank you for your time. Thank you for presenting this very fascinating information to our webinar series. And we will meet again, isn't it, Michaela?
Yeah, thank you for your historical overview, but also for the clinical cases and the latest research updates you presented. It will be very interesting and also fundamental for our students to learn the biological and the neurophysiological changes that underline this complex pathology. So thank you.